We've got lots of other topical therapies. There's a combination steroid vitamin D product, and because it's a combination drug, I think it probably works better than either of the two components. Well, it's been in the clinical trials, they compared it to the either clinical component alone, and it was clearly better. But I think in some patients, it works better than giving patients both drugs separately. Because if you give them both drugs separately, it's too complicated. They don't do it. You give them one drug, they get better. Now, I was at a meeting where the dermatologist, Peter Heald from Yale, was talking about what he called coral reef psoriasis, a form of psoriasis with plaques that are just so thick. He said that, I remember him saying, coral reef psoriasis is a marker for resistance to topical therapy because the medicines just don't penetrate. And I thought to myself, he's half right. This kind of psoriasis is a marker for resistance to topical therapy. But it's not because the medicines don't penetrate. Normal skin has good barrier function. Diseased skin has poor barrier function. You measure transepidermal water loss through this lesion, you'll see it's off the chart. Medicines penetrate through something like this just fine. Why is this a marker for resistance to topical therapy if it's not poor penetration of the drug? Yes, this is a marker for somebody. Anybody who lets their plaques get like this is not using their medicine. So when they came out with that clobetasol spray product, before it hit the market, there was an advisory board meeting. And there were boxes of this stuff sitting on the table. At the end of the meeting, I grabbed some of those boxes and I stuck them in my pocket. And I waited for a patient like this to come. This patient had failed all the topicals. They had failed the Tanacept. And I said to the patient, here, try this spray. Put it on twice a day. I'll see you back in 3 days. Okay, why 3 days? Well, if the dentist put his hand on your shoulder and said, listen, I'm really worried about your gums. I want you to floss twice a day. I'm going to see you back in 3 days. You think you'd floss those 3 days? Yes, you probably floss really well those 3 days. So he comes back in 3 days and he goes, oh my God, this stuff is great. It's working already. Saw him back at 2 weeks. The plaques were almost completely gone. Now, there was no penetration enhancer. There was no wrapping it with saran wrap. All of those things would have made compliance worse. So if you recognize the patients who are poorly compliant, the solution is not to give them stronger steroids, which they're afraid of. The solution is not to make it more complicated by giving them more and more different things to do. The solution is simplify things, and make it easy for them, and do some of the other tricks that get people to use their medicines. Here was a study we did in acne where we compared one product that contained two drugs to adherence to the same two products as separate treatments. And clearly, better compliance when you simplify the regimen for the patients. In atopic dermatitis, we did a study where we gave people a twice-a-day therapy to use, and we either brought them back at 4 weeks or we brought them back at 2 weeks. Brought them back at 1 week and then at 4 weeks. And that extra visit drives their adherence behavior. This is a great study where that combination steroid vitamin D product was used in study after study after study, different locations around the world. Dr. Papp, who spoke here in Canada, had one of them. This is Denmark. This guy's in France. And you see in study after study, they get consistently similar results, except for this one study that was done in France that the patients didn't do as well. Why didn't they do as well? Because you'll notice they didn't bring them back for a 1-week return visit. Now, if you don't tell patients how to use the medicine, you make it harder for them. And a study was done where a dermatology resident, recorded whether the patient was told the diagnosis, was told how to use the medicine, and it was shocking how seldomly basic things were not told to the patients. Now, I sort of feel like giving people the instructions in writing is not going to solve all adherence problems. But if you don't give it to them in writing, you failed. You may have failed from the beginning. And there have been a couple experiences I've had that highlighted this for me. One was the mom of an eczema patient who came to see me with her baby. The baby had terrible dry skin, and they'd seen other dermatologists. I asked the mom, what are you bathing your child with? And the mom says, ivory soap. Now, dermatologists would tell you ivory is the most drying soap there is. They would recommend something like Dove, which is really mild. I asked the patient, what did the previous dermatologist tell you to do? What soap did they tell you? The previous dermatologist said I should use Dove or ivory. Okay? Now, what did the previous dermatologist actually tell this mom? Almost certainly the previous dermatologist told the mom, use Dove, not ivory. But it wasn't in writing. And by the time mom got to the store, she remembered Dove or ivory. I mean, that's like the simplest instruction you could possibly imagine, and they can't remember it. So anything you want them to remember, you have to give it to them in writing. I once visited a friend of mine, Ira Davis. He and I trained in North Carolina in dermatology. He moved back to New York for his practice. And I went to visit him once, and like 6 weeks before the visit, I was talking to him about how am I going to get to him once I arrive at the airport. And he said, Steve, you're going to arrive at the U.S. Airways terminal, and you're going to come down an escalator into baggage claim. And at the bottom of the escalator, there's going to be these Russian limousine drivers, and they're going to try to take your business. Do not go with them, okay? Just go outside to the taxis. Here in New York, the taxis are well-regulated, they're safe, and they're inexpensive. You go with the Russian limo driver, you're going to get way overcharged, and they might take you to an alley and rob you or worse, okay? Fine. So 6 weeks later, I arrive at the U.S. Airways terminal at LaGuardia, and I'm coming down the escalator to baggage claim, and there's the Russian limo driver. And I go, I remember Iris said something about the Russian limo driver, but I can't remember whether it was to take it or not take it. I guess it must have been to take it, and so I went with the Russian limo driver. And I was overcharged, but that was all that happened. So, put it in writing. If you can make, specific plans, and now with digital records and stuff, EMRs, you ought to have codes that allow you to spit out what you're telling patients automatically, or you can type it up and copy it with a Xerox machine and just hand it to people. You tell them the same thing over and over again. Why not make it efficient and give it to them in writing? When you're dealing with kids, I think the sticker calendar is the most powerful force. You can potty train a kid with one of these. You just give them a calendar, 5 cents worth of stickers. You give them a sticker for every time they do something right, and you don't even have to give them a prize. It's just the stickers on the chart is enough to drive the behavior. We use this with our residents. We have their names up on a chart on the wall. We give them gold stars. It's coercive. The IRB would never let us do this if we were to ask them if it was okay. Side effects, are a mixed bag. Side effects scare people, but if you can use them like judo and turn them to your advantage, they can be a powerful tool. One dermatologist told me that when she treats women with hormonally induced acne with spironolactone, which is also a diuretic, she tells them, now, unfortunately, this drug is also a diuretic, and you may notice some weight loss while you're on it. I'm treating scalp psoriasis, and if you see a patient with scalp psoriasis, all you got to do is give them a little bit of clobetasol solution to use, but the clobetasol solution has alcohol, and it may sting, And so one dermatologist told me that he tells patients, now this may sting, that's because it's so strong. But I don't like that because some patients are afraid of strong steroids. So what I tell them is, now this may sting, that's a sign that it's working. Is it really a sign that it's working? I don't lie. Yeah, it means they got it on. If they got it on, then it's working, If it doesn't sting, it means they didn't get it on the scalp. And then, we have a lot of young, attractive female dermatologists nowadays, and if they are taking care of a guy with scalp psoriasis, they can tell him something like, now this may sting. A lot of guys don't have what it takes to use this stuff. We talked yesterday about putting risk into perspective, so in the interest of time, I won't spend any more time on that. We talked about using the fact sheets from our Psoriasis Foundation to educate people about their options. Cost is an issue that I alluded to with regard to skin cap. I I like to prescribe low-cost medicines. I like to give patients their options and let them choose. If they want to choose a higher-priced, branded combination drug because they'll use it better, if that's what they want, that's fine with me. We got all kinds of co-pay programs now. One of the things I do regularly, and I've even built it into the EMR that we use, is for a lot of the medications I prescribe, I have on the electronic prescription that goes to the pharmacy, it goes with my cell phone number, and it says, if you have a less expensive option, feel free to switch to it, or if you have any questions, just call me. Because nowadays, generic topical steroids cost a lot of money. And if I prescribe fluocinolone and that particular pharmacy has betamethasone inexpensively, it's totally okay with me if they switch to the less expensive one if that's what the patient wants. And so I would like that to happen automatically, but I give them my cell phone number, if they feel the need to call me to approve it. Assessing adherence is complicated if you don't have those computer chips, We talked about, asking patients, are you keeping the extra syringes you've accumulated refrigerated like you're supposed to? The correct answer is, Doc, I don't know what you're talking about. I don't have any extra syringes. If they tell you they're refrigerating the extras, you know they're not taking the medicine regularly. You can ask them, what do you do with the extra medicine you have left over at the end of a prescription? Do you keep it in the medicine cabinet or in a kitchen cabinet? Do you throw it in the toilet? Do you take it back to the pharmacy? What do you do with it? And if they say, I don't know what you're talking about, I don't have any extra medicine, well, then you know they're using it right. If they say anything else, you're on to them. I talked about behavioral economics a little bit yesterday. One of the studies that Dan Ariely has published a book about cheating. I think it's a fascinating book. He does mostly experiments in college students. He gives them a test, a math test with 20 questions that are so complicated that if you administer it to any 20 college students, on average, they will get 8 answers right. If you have them take the test, grade their sheets, shred them, and they tell you how many they got right, and you pay them for each one, instead of averaging 8, somehow they manage to average 12. Okay? And then he manipulates the environment and sees what causes the level of cheating to increase, what causes it to decrease. One of the things he finds is that if at the beginning of the test you ask these kids, how many of the 10 commandments can you name? And then report their results, they report that they got 8 right on average. They report that they don't cheat at all. And it doesn't matter what religion they belong to. It doesn't matter whether they're religious or not. It doesn't matter how many of the 10 commandments they accurately named, or if they came up with 10 commandments that aren't part of the 10 commandments. But just putting them in that frame of mind eliminates cheating. So I got on eBay and I bought myself a 10 commandments tie. And I, wear it sometimes, and I talk to people about it. And then I ask them, so how often are you putting the medicine on? Or I may talk to them here in North Carolina. Well, what church do you go to? Oh, that's very nice. How often are you putting the medicine on? To get them in the right frame of reference so that I get an accurate answer. People care about losses much more than they do gains. Let's not talk about sunscreen. Let's talk about my use of Simvastatin. Okay, my gerontologist put me on Simvastatin. I go through periods where I take it regularly, and then I go through periods where I don't take it very regularly. Right now, I'm in a period of not taking it very regularly. If my gerontologist tells me, Steve, we don't know for sure, but if you take the Simvastatin regularly, you might live, a year longer. It doesn't really have much impact on me. But if my gerontologist were to say, Steve, I want you to take the Simvastatin every day. If you don't take it every day, you're going to die a year sooner. That would have an enormous impact on whether I took it or not, because I do not want to die a year sooner. What's the difference between dying a year sooner and living a year longer? No difference mathematically, but enormous difference between your ears. And so if you're going to present something to somebody about joint progression, for example, I wouldn't say, take this medicine and you'll maintain joint function longer. I might say, take this medicine regularly so that you don't lose the function in your hands. Framing. I mentioned something about framing, about how if you talk about risks being, more than a lightning strike, that doesn't sound nearly as bad as being less than a coin flip. 0 is very special. you know, it's really nice when there's no chance of something happening. If there's a 1 in 100 chance of something happening, that's much worse than a 0 chance of something happening. The difference between 1 in 100 and 2 in 100, to the human mind, it makes almost no difference at all. But between 0 and 1 in 100 makes an enormous difference. And so the human brain doesn't interpret small events very well. And that's why I think talking about 99 out of 100 have no problem, or 999 out of 1,000 have no problem, that's much more reassuring than, hearing that only 1 in 1,000 something bad happens. Because they're going to be like, ooh, something bad happens. Salience is kind of interesting. One of the examples of this is if you ask people what's more likely, a Richter scale 8 earthquake in San Francisco that causes major flooding, or a major flood west of the Mississippi. Well, most people would say, well, the earthquake in San Francisco is more likely. Well, that's impossible, because if there's a flood west of the Mississippi, then that flood in San Francisco, that's west of the Mississippi. So it has to be that it's more likely to have a flood west of the Mississippi than this event in San Francisco, because San Francisco is west of the Mississippi. But that's not the way the human mind works. The human mind grabs onto things that are, that create a visual picture in people's heads. And so instead of telling people, use sunscreen so you don't get skin cancer, I tell them, use sunscreen so you don't get a golf ball-sized ulcerating tumor of your nose that smells bad and it drains. And the surgeon, when they take it off, they're going to have to take off the whole nose. But don't worry, because they make these rubber prostheses now that look almost exactly like a normal nose. Okay? That presents a picture in people's mind that they are not going to forget, telling them avoiding skin cancer. Well, if you avoid skin cancer, you avoid the golf ball-sized tumor, but it doesn't have the same effect in people's minds. So, painting pictures can be quite valuable. Okay. What do you do for truly resistant patients? I work in an academic center. We see resistant patients. We select for people with really bad disease that does not get better. We frequently see people in dermatology say, "Doctor, you're the 5th dermatologist I've seen for this. What is the likelihood that the previous 5 dermatologists made the wrong diagnosis?" Yeah, 0, okay? What's the likelihood that 5 of previous dermatologists wouldn't have stumbled, not one of them would have stumbled on the right treatment? 0. It's just not possible. What we are reaching for is poor adherence. If you are working in the academic environment, you are at the top of the non-adherence pyramid. I remember reading an expert in dermatology talking about the best thing he learned from a mentor at NYU. It was that, if you're going to be the expert, you need one more treatment that the other guys don't know about. And I believe you need one more way to get people to use their medicine than the other guys know about. Because when you see resistant disease, my guess is it's not T cells with steroid deficiencies. The mutated steroid receptors. It's probably not what's going on. It's probably they're not using the medicine. You can do all kinds of things. You can switch them to an office-administered treatment like infliximab. You can hospitalize them, give them medicine there. You can bring them in for their methotrexate injections. They talk about how, sub-Q methotrexate works better because of better pharmacokinetics and stuff. Maybe there's something to that. But I think there's a high likelihood that patients are terrified of methotrexate, and at home they're just not taking it the way you told them to, and you give to them the shots in the office, and they get better. In dermatology, we're dealing with topical treatments, and one of the things I can do is give people phototherapy. I tell them, all right, here's what we're going to do. We're going to have you come in every day for a light treatment. And as long as you're here, we're going to apply your topical treatment before the light treatment to make the light penetrate better. And if you don't have a light box, you can do this with a handheld woods lamp or something. It doesn't really matter what kind of light you use, because what's making them better is the fact they're coming in and you're getting the chance to put the treatment on them. Now, one of the most resistant conditions in dermatology is scalp psoriasis. For first 12 years I ran our psoriasis treatment center, I could not get anybody's scalp cleared up. And there's 3 reasons it doesn't get better. The wrong diagnosis, the wrong treatment, and poor penetration of topical therapy are not the 3 reasons it doesn't get better. Y'all know the 3 reasons it doesn't get better? Poor compliance, Poor compliance and poor compliance, yes. I mean, think about it. People don't take their pills. We already know that. They're not going to rub slop on their skin. Now you're going to try to get them to put a topical past their hair. It is the mother of all compliance problems. And if you can get people to clear up their scalp, then you have a black belt in mastering, getting patients to use their medications. It's not poor. Dermatologists think that the stuff doesn't penetrate, but scalp has penetration characteristics like axilla. I mean, the stuff goes in just great, and we're talking about diseased skin, so it penetrates even better. They also talk in dermatology about how people scratch their scalps, and that's why the Kebnerization of the scalp makes the disease resistant. But people scratch all their psoriasis. That's not what makes scalp uniquely resistant to therapy. Now, even today, I think people still in dermatology don't appreciate the magnitude of the poor compliance problem in the scalp. Because here's from an excerpt from the book Mild to Moderate Psoriasis, published in 2009. International expert published this on how he manages scalp psoriasis. First, you have to descale them. You can use that with topical salicylic acid or urea, 40% in a wash-off ointment to enhance descaling. Who here is going to put a greasy ointment on their scalp tonight if I asked you to? All right? No, you're not going to do it? Yeah, I didn't think so. Okay. Then, if that isn't complicated enough, they want you to use a steroid or a vitamin D lotion or both. A lotion, vitamin D, and a super potent topical steroid once a day. At least they say use a well-accepted vehicle once a day. And then if this doesn't work after 8 weeks, 8 weeks? They're like the piano teacher says, do it and come back in 8 weeks. 8 weeks, then because they're used to it not working, then you got to do ultraviolet light therapy for the scalp, or this anthranol or tar products. And then if that doesn't work, you got to maybe culture them and start systemic antifungal therapy. Yes, there's a biome, but I don't think you have to do all this. Then there's a third phase where you stabilize them, and then a fourth maintenance phase. This is just ridiculously if people won't take a pill, are they going to do this on their scalp? It's just insane. I got a 4-phase treatment too: clearing, maintenance, when tachyphylaxis occurs, and what to do if they failed topical clobetasol from another dermatologist. In the clearing phase, I get them to put the topical clobetasol on. They clear right up. In the maintenance phase, I get them to use the topical clobetasol as needed. And then eventually, after about a year and a half, it stops working. So then I get them to start using it again. And then if they failed from the previous dermatologist, I get them to actually use it well, and they clear right up. Now, how do I get them to do this? I often see patients with psoriasis on Thursday mornings. So I give them the prescription for the topical clobetasol, and I tell them, I want you to use this for 3 days. They say, stop. Dr. Feldman, are you listening to me? I just told you that I've tried this stuff. It doesn't work. I put my hand on their shoulder, and I say, trust me. Just trust me for 3 days. It's going to work. I guarantee it. Using the word guarantee is a little strong. 3 days, guarantee it's going to work. I'll tell you what, I'll see you back in just 3 days. In fact, better than that, let me write down my cell phone number for you. So I take out my business card, I write down my cell phone number, I say, 3 days, you call me Sunday night, and let me know how this is doing. Now, it may sting. The stinging is a sign that it's working. Also, you have so much hair, and women love being told, oh, you have so much hair. You have so much hair, you couldn't possibly do this on your own. Either your mother, your daughter, your sister, your spouse has to help you put this on. It's like getting your hair colored. You probably have no idea what that's like. I want you to separate the scalp, do one line, move it over, do the second line. It's a 2-person job. Call me Sunday because I want to know how you're doing. They call me Sunday. I don't answer the phone. Why would I answer the phone? That doesn't change what they did in the previous 3 days. What's happened has already happened. They leave me a message. The message is, Dr. Feldman, I am so glad you didn't pick up the phone because I really didn't want to bother you on Sunday. But you said I had to call. I just wanted to let you know it worked like a miracle. And clears right up. Now, I don't pre-print my cell phone number on my business card and give it to everybody. Why would that be bad? Well, if my gerontologist gave me her cell phone number, I'd never call her. I give my cell phone number out to patients left and right, okay? But if I pre-print it on my card, they know I give it to everybody. and I want them to think that I care about them, that I think they're special. So I handwrite it on there and give it to them. And they think, oh, Dr. Feldman, I can trust him. I've never had a doctor give me the cell phone number before. He's a trustworthy doctor. They may open the package insert and see horrible things, but they go, I trust Dr. Feldman. And if anything happened, I have his cell phone number. I could call him. So they use it. They clear right up. It's a fabulously powerful tool. And I figure I'm never going to get sued by a patient who I gave my cell phone number to because, they think I walk on water. All right. Other things specific to biologics. Habit is the key thing. If I see the patient, I don't have to see the scalp psoriasis patient back every 3 days for the rest of their life. In those 3 days, I forced them to fill the prescription right away. Remember at the very beginning, we said they may not fill their prescriptions. If they have to call me in 3 days, they have to fill the prescription right away. So they fill the prescription right away. They do it twice a day. Now they're in the habit of doing it, and they see that it works. They're confident in their ability to control the disease. I don't need to see them ever again. They could go to the family doctor for the refills. They've got this under control. Getting them in the habit is key. So the same thing with the biologics. You want to get patients in the habit. And one of the things you can do is have them build it into their routine. Pick a day of the week. Stick with that day of the week every time. If you go to church every Sunday, do it right before you go to church or right after, or whatever works best for you. Another thing I would encourage you to do if you can is make them think it was their idea, okay? So rather than tell them what to do, ask them, have you thought of any of the following things as ways to remind yourself to use the medicine, like using it the same day every week? Because if they think it was their idea, they will be much more attached to it than being told what to do by an authority figure, which, as we saw with acne, could backfire. One of the best examples is I got this athlete's foot problem, with the fungus between the toes. If I put a little topical terbinafine on a couple times a week, no problem, it stays gone. How do I remember to do that? Well, I put the antifungal cream on top of my socks. From personal experience, if I put that stuff anywhere else in the house, my habit in the morning is to put my shoes and socks on and then remember, the antifungal cream. I'll do it tomorrow, But if it's on top of my socks, I can't continue my routine until I go through the medicine. Anytime you can make a medicine you want them to use, force it into their routine, I think it's a huge benefit. Is poor adherence bad? In a way, it's not bad, because if people are doing well and they cut back on their use of the medicine, I presume it reduced the side effects. That's why I don't think I will ever find steroid atrophy to scalp psoriasis. As soon as people's scalp psoriasis is controlled well enough, they stop the therapy. And there are exceptions, and obsessive compulsive people who use things and overuse them, even when they don't need them anymore. With topical steroids, I don't worry about this, but we've sort of talked about this with respect to biologics, because you can develop antibodies and stuff. And so with antibodies, there may be reasons in some cases where you want people to do things regularly. Last thing I'll just show you is, I thought, I found with scalp psoriasis, if I bring people back in 3 days, they use the medicine. Then I found that if I gave them the cell phone number, they used the medicine. Then I thought, well, what if I didn't have any personal interaction with them, but I made them feel like there was a personal interaction by surveying them over the internet? And I took patients with acne, and I randomized them to 2 groups. Both groups get a once-a-day topical acne regimen with a computer chip cap recording what they do. Half of them, I just tell them to come back in 6 and 12 weeks. The other half, I tell them to come back in 6 and 12 weeks, but I also send them this survey to fill out once a week, asking them, how many times did you use the medicine? How well is it working for you? Have any problems with it, fitting into your lifestyle? And the group that I send the survey to uses the medicine 3 times as much as the group where I have no contact with them between visits. Okay? It's kind of like if the piano teacher, instead of having the lesson, said, listen, I'm going to call and we're going to talk once a week and you're going to report to me how things are going. Just the fact that people know there's somebody following up on them drives their behavior. And there may be ways that we can, automate this. Wake Forest has submitted a patent, has spun off a company to commercialize this technology. So, to summarize, well, adherence is everything. Okay, thank you very much.